No, sir, you can share your slide.
It is there.
Sir, we are live now. You may start.
Full screen, please. Diksha. Full screen. Good evening, ladies and gentlemen. Welcome to the 6th episode of the web series titled Blood, the Life Savior. And today we have exclusive presence of faculty and team members from prestigious All India Institute of Medical Science. And today's topic is equally interesting, biocytopenia and a clot. All this has been possible courtesy our course directors, and a warm welcome to them, Dr. Biju George and Dr. Joseph Johnson. And in the same breath, I would also like to welcome Professor Dr. Tulika Seth ma'am, Dr. Mukul Agarwal, Dr. Richa Chauhan, and Dr. Kartikeya Seni. We assure you that in the coming 1 hour is going to be extremely enriching for all of us. Dr. Biju George needs no introduction, ladies and gentlemen. Sir is professor at Department of Clinical Hematology and CMC Hospital, Vellore. Close to 300 plus publications in all journal of repute, contribution of 6 book chapters, many contributions in the field of bone marrow transplant and hematology, which is being followed as a national standard protocol today. And we would also like to warmly welcome Dr. Joseph Johnson, Professor and Head Department of Clinical Hematology at CMC Hospital, Ludhiana. Sir has 30 international and 38 national publications. He has contributions in more than 7 book chapters. He is the principal investigator in 20 plus clinical trials. A lot of awards and recognitions, and his contribution to hematology is immense as well. Thank you, both the program directors, for taking the entire educational web series forward. May I request Dr. Joseph John to introduce Professor Dr. Tulika Seth and take it forward from there.
It's my honor and pleasure to introduce Dr. Tulika. We work closely. She's a professor in the Department of Hematology, All India Institute of Medical Science, a guide and a co-guide for many students, and authored multiple papers and chapters. Multiple positions she has held and has been closely working with the guidelines on thalassemia, sickle cell, and of course, a lot on hemophilia and costing and health economics. And she has multiple memberships, as you see. And today it is her team who's going to present the benign hematology series today. And over to Dr. Tulika to introduce your team members and give an overview on what we are in store of. Thank you.
So thank you, Dr. Joseph, and thank you, Dr. Biju, for this opportunity and this wonderful platform. I'm delighted to introduce my team today. We have Dr. Mukul Agarwal, who's Associate Professor Clinical Hematology here at AIIMS New Delhi. He's currently the chair of the Inherited Bone Marrow Failure Syndrome chapter of IAP. He has numerous projects and multiple original research papers and publications. We have Dr. Richa Chauhan, who's Assistant Professor of Hematopathology at AIIMS New Delhi. She's very dynamic and she's a leader in the NABL accreditation and a great asset to us, and has started her academic career with a wonderful number of projects. And we have our very able senior resident, Dr. Kartikeya Seni, who will be discussing a very interesting case. And over to you. And I'm sure we'll have a lot of discussion today. Thank you.
Hello, are my slides visible?
Yes, can you put them in the
Your
full-
slide is visible, but can you go with the full screen?
Yes.
Okay, perfect. Oh, something happened. They went back to the other.
Can you go for the full screen?
Yes. Are my slides now visible?
Yes.
Yeah, now it's okay. Can go ahead.
Thank you for the opportunity to present the case. From hemolysis with thrombosis, a case of portal vein thrombosis with pancytopenia. Mr. X, a resident of Panipat, Haryana, presented to us with the complaints of generalized weakness, easy fatigability, shortness of breath from the last 1 year, which was insidious in onset and progressive in nature. And subsequently, he developed abdominal distension and yellowish discoloration of sclera, which was from the past 6 months, subsequent to which he first presented to a medical facility outside. There was no significant past history. However, there was history of blood transfusion, a total of 4 till now, requiring transfusions every 40 to 45 days from the last 6 months. And the patient was not aware of the reason, but he was told to have low hemoglobin. The diagnosis was not made. There was no other significant history from the patient side. On examination, the patient had a pallor, had icterus. The rest of the head to toe examination was within normal limits. The respiratory cardiovascular system was normal. And on abdominal examination, the patient had a palpable spleen of 10 centimeter, which was palpated below the left costal margin. The rest of the abdominal examination was also non-contributory. Coming to the negative history, there were no history of repeated episodes of weakness with jaundice in the past. There was no history of altered mental status, sleep-wake disturbances, or tremors. There was no history of any other autoimmune stigmata. There was no history of any drug intake. Neither there was any history of weight loss, diaphoresis, bony pains, or fever spikes. No history of venous thromboembolism in the past, and no history of vein abdomen or any altered bowel habits. Differentials, what we can think of on the basis of the given history and examination. Coming to the first major system possibilities, a cardiac illness is a possibility which led to a right-sided heart failure leading to congestive hepatomegaly. However, there were no cardiac findings, neither the spleen was palpable or was tender in the right hypochondrium, so cardiac illnesses look less likely. Another system possibility can be liver due to the presence of jaundice, a palpable spleen, and history of multiple blood transfusions, which could be explained by recurrent GI blood losses. And the more likely possibility of a hematological disorder due to the presence of jaundice and history of blood transfusions and the presence of spleen, which could be an evidence of ongoing hemolysis. We reviewed the investigations which the patient had already done from outside. The patient had a hemoglobin of 9.1, a TLC of around 3,000, a platelet count of around 60,000, and LDH, which was around 4 times elevated the upper normal limits. SGOT, SGPT were normal. Increased bilirubin, which was predominantly indirect in nature, and an ultrasound abdomen, which suggested a portal vein which was attenuated with the presence of multiple tortuous vascular channels with splenomegaly. However, the liver ecotexture were normal and the hepatic veins were also normal and showed no signs of obstruction. Based on the current investigation and current examination history, the possibility of a liver disease also looks less likely because the liver ecotexture was normal, the hepatic veins are normal, the SGOT, SGPT is normal, and the bilirubin elevation is predominantly indirect in nature. The differential, the patient has a portal vein thrombosis with splenomegaly, with pancytopenia and evidence of hemolysis. In the order of less possibilities, lesser possibility, the diagnosis can be an AIHA with hemolysis leading to thrombosis, with hypersplenism explaining the pancytopenia, an MPN which could lead to a splanchnic vein thrombosis with splenomegaly, with bone marrow fibrosis explaining the pancytopenia, a sickle cell disease, thalassemia, or any other non-spherocytic hemolytic anemia, which could rarely lead to a splanchnic vein thrombosis. However, the possibility of the same is very low. Similarly, for Wilson disease, which could explain the hemolysis and cytopenias. And other more likelihood possibilities were NCPF, which could lead to portal hypertension, hypersplenism. However, the thrombosis is not explained by NCPF, and also Apla's syndrome, which could lead to a splanchnic vein thrombosis with hypersplenism or the immune cytopenias explaining the presence of pancytopenia in the patient. However, out of all these differential, the more likelihood possibility was of PNH due to the evidence of hemolysis, presence of cytopenias, and portal vein thrombosis. However, there were some points against the PNH on the available information, which include there was no history of hematuria. However, it is not present in all the patients, and a spleen which was palpable 10 centimeter below the left costal margin. Finding such a huge spleen in PNH is generally rare. We investigated the patient further. The patient on our investigation had a hemoglobin of 6.4, TLC of around 2,000, a platelet count of around 20,000, and a corrected retic count of around 1.8%. The peripheral smear did not have any evidence of left shift myelopoiesis or basophilia. However, there were few phagocytes, but the sample was post-transfusion. The LDH was exponentially raised. It was around the range of 3,000, the normal range being less than 250. SGPT, SGOT were again normal, and the bilirubin was elevated with predominant component being the indirect bilirubin. The Coombs, direct and indirect, both were negative. Now revisiting our differential MPN, for MPN there is no evidence of left shift, no evidence of basophilia, teardrops, and again pancytopenia is rare in MPN unless in the burnt out stages. AIHA, the Coombs was negative, the retic was low, although the possibility of Coombs negative AIHA still persists, but pancytopenia is not explained by AIHA. Sickle thal, less likely, not explaining the pancytopenia, no smear findings, and very large spleen for a sickle cell disease. APLA workup was negative. PNH is a strong possibility because the Coombs is negative. There is evidence of hemolysis, the retic is low, there is splanchnic vein thrombosis, and there is no history of any family history of blood transfusion or no history of any blood transfusion in the family. Coming to some basics of PNH. PNH is a rare disorder which is caused by the complement-mediated hemolysis and thrombosis through the alternative pathway, and it is caused by an acquired mutation in the hematopoietic stem cells, which explain the absence of any family history or presence of any complaints in the childhood of the patient. It is a complement-driven hemolytic anemia due to the clonal expansion of stem cells harboring a somatic PIG-A mutation. The PIG-A synthesizes the GPI anchors, including CD55, CD59, which both of are which inhibit the complement-driven erythrocyte lysis, which leads to lysis of the erythrocytes in the presence of complement activation. Again, the complement activation leads to the platelet activation as well as the leukocyte activation, which causes the presence of thrombosis in PNH. Also, there is an intravascular hemolysis leading to the release of free hemoglobin, which scavenges the nitric oxide, leading to end organ damages, as well as the presence of smooth muscle dystonias. The annual incidence as well as the 15-year prevalence of PNH is around 1.59 per 1 lakh patient, and it can occur at any age, typically occurs in the 3rd and the 4th decade. However, it has been reported to occur in all the age groups. And it is associated with life-threatening thromboembolic events, which are again the most common cause of death in patients with PNH, and organ damages, especially renal failure due to the hemoglobinuria. Around 35% patients of PNH die in the 5-year despite the best possible management available at our disposal. The historical survival rates being around 80% at the end of 5 years and around 50% at the end of 10 years. PNH frequently involves multiple sites, including unusual sites such as hepatic veins, cavernous sinus, CNS, mesenteric veins, or even dermal veins, and commonly presents with dyspnea, hemoglobinuria, impaired renal function, and smooth muscle dystonias, including the abdominal pain, erectile dysfunction, and dysphagias. The PNH can be broadly classified into 3 classes. The first being the classical PNH with a very heavy clone size of greater than 50%, which leads to a florid intravascular hemolysis, and there is generally a lack of other bone marrow failure syndromes. PNH can also occur in the setting of other bone anemia as well as MDS. The clone size is generally less than 50%, and there is some evidence of intravascular hemolysis, but it is generally not the first complaint. And there can be a subclinical PNH clone, and there is absence of clinical and laboratory evidence of thromboembolism is much earlier than 1.5%, 1.5 times. Survival is significantly lesser in patients who present with PNH or subsequently develop thromboembolism during the course with PNH. Coming back to our patient was advised bone marrow study and PNH by flow cytometry. The bone marrow study of the patient revealed an hypercellular bone marrow with an overall cellularity of around 80 to 85%, which was the erythroids were mildly megaloblastic, and there was hyperplasia of the erythroids, and there was no evidence of dysphosis. The cytogenetics was normal. On the PNS, there was a large monocyte and granulocyte. Both were large clone involving both the monocytes and granulocyte involving around 75% of each. The patient was diagnosed as a classic PNH and was explained by Dr. Mukul sir in the subsequent slides. The patient was not paid affordable for eculizumab and was counseled for a bone marrow transplant, and HLA matching was requested. Counseled about low dose steroid use during the episodes of hemolysis, and the patient has been now following up with us for the last 1 year. The cytopenias are persisting, not improving with danazol, and the blood transfusion requirements is still maintained and has not reduced or increased post the diagnosis and the treatment. The patient has been counseled again for BMT and requested to get an HLA match done. There are no episodes of jaundice. There are episodes of jaundice, but which are not associated with the episodes of hemoglobinuria till now. And there are no episodes of pain abdomen and repeat on venous thromboembolism. Thank you.
Thank you, Dr. Karthik, for a good presentation. Maybe we can move over to Dr. Richa for her part.
Yeah, am I audible?
Yes.
Good evening, everybody. Thank you for this opportunity, ma'am. So, I'll be touching upon the pathobiology and diagnosis of PNH. So, just a brief sentence about historical perspective that this disease is not new. It has been known since 1882 when Paul Strubing first described a case, but he couldn't label the disease, so his name got lost somewhere. But after almost 5 decades, we now know that his description of the patient was one of the finest. And it was later in 1911 and 22 that Marcia Fava and Micheli described two PNH cases similar to Paul Strubing. They named it as a syndrome after their name. And then in 1925, Enneking coined the term paroxysmal nocturnal hemoglobinuria. We have several publications that have highlighted various aspects of PNH, and still the disease is under study because of the enigma that follows, the triad that this disease is associated with. So, deficiency of glycoprotein anchored proteins. Just 1 second. Deficiency of glycoprotein GPI anchor proteins is cause of PNH that is known since 1980. So, what is glycoprotein anchor? As Dr. Karthike has just mentioned, that the disease is due to mutation in PIG-A. So, this is a gene that contributes to the formation of an anchor protein that is attached to cell surface, and it helps in attachment of various proteins that are related to blood group antigens, receptors, complement receptors, various proteins that are attached to the membrane via these anchor proteins. Now, there are several PIG genes. PIG, what is PIG? Phosphatidylinositol glycan anchor. Okay, this class A is one that is important in PNH, mutation of which leads to PNH. But there are several other PIG genes which are important in multi-step formation of the this long multipeptide that is the anchor protein. But why is PIG-A relevant? Because it is the proximal most gene that is involved in the formation of this protein. So proximal, the protein involved and deficiency of this protein will cause complete loss of GPI anchor vis-a-vis a gene that is involved in formation of an epitope that is later on added to the this protein. So coming to what are the proteins that are GPI anchored. So we know that mature cells are to be studied for diagnosis of PNH because developing cells in marrow will lack, because they are under development, they will lack these antigens. So in different blood, there were several of the antigens that were discovered to be GPI linked, and some of them are used for diagnosis, and some of them, and many of them are involved in the pathobiology. Common ones that we know that in RBC, CD55, 59 are absent. In monocytes, CD14 is absent, CD157 is absent, CD55. In granulocytes, also CD24 and CD157 and so on. So, coming to the role of these proteins, these GPI-linked markers on red cells are very important because they prevent spontaneous complement-mediated hemolysis. They protect the RBCs from complement-mediated activation of alternate complement pathway and spontaneous hemolysis. They are complement regulators, CD55, decay accelerating factor, and CD59, membrane inhibitor of reactive lysis. So, similarly, there are other proteins that are involved in the pathogenesis, that is from especially thrombosis and other features that we see in PNH. For example, NAP is reduced in PNH, we know, because again, NAP is a GPI-linked protein. So this is a cartoon showing how several pathways activate the terminal complex, and complement is regulated on the RBCs through CD55 and 59. Complement activation is through alternate complement pathway, which causes activation of C3 convertase, wherein C3 is converted to C3b, and C3b along with C5 convertase helps in activation of C5, where C5b then forms a membrane attack complex, and this membrane attack complex is limited by the presence of TAF and MERL, that is CD55, 59 on the normal RBCs, but because of the absence in PNH clones, this is formed and there is hemolysis. So we know that how the mature cells behave when they have lost the GPI anchor, but the somatic mutations affect the hematopoietic stem cells in the marrow. Now, hematopoietic stem cells, the PNH hematopoietic stem cells that lack GPI, that will form cells that will lack GPI anchors, can coexist with the normal hematopoietic stem cells, but in a minor clone. But they have no capability of expanding. So how does the PNH clone expand? So when there is an immune attack in acquired aplastic anemia, these cells evade immune attack. The PNH hematopoietic stem cells, they evade immune attack. Mutation that can proliferative potential to these cells, they slowly can expand and replace the marrow. And otherwise, in aplastic anemia, they can just be as for years they can exist as a stable clone.
Maybe switch off your camera, Dr.
certain ligand. Hello, am I audible?
Your network's a little unstable. Maybe switch off your camera.
Yeah, sure, ma'am.
Thank you.
Yes. Am I audible now?
Yeah, better.
And they can escape recognition by CD4 and CD8 positive T cells. Hence, they evade immune attack. So I talked of big A mutations. Now there are some lesions that cause complete inactivation of IgA. Now, the normal red cells or WBCs are called PNH1 clone. They don't have any loss of GPI proteins because they have no mutation. Now, PNH2, when there and hence they will have either intermittent hemolysis or a slower progression. But marked increase in marked absence of these glycoprotein GPI anchored proteins can cause a very with constant or more frequent hemoglobinuria. So, as Dr. Karthik has already described, there are three subtypes of PNH. The classic PNH, wherein the clone size is very high, that is also called hemolytic PNH, a PNH in the setting of other bone marrow depends on the clone size on RBCs. If it is more than 50%, there's a possibility of constant hemoglobinuria that can also affect kidneys. So when should you perform testing for PNH? So when there is an intravascular hemolysis as evidenced by hemoglobinuria or evidence of unexplained cytopenias along with thrombosis, especially along with thrombosis. If you are evaluating a Coombs negative hemolytic anemia, which is non-schistocytic and non-infectious in origin, you should think of PNH. I just talked about thrombosis, especially in unusual sites, we should be thinking of PNH. Then so, how do we diagnose PNH? In olden times, Ham's test. So, Dr. Ham. He came up with this test where he demonstrated that PNH cells are unusually sensitive to complement mediated. Then, with the help of magnesium ion, the lysis of the red cells occur, and which does not occur in a control sample. So this was a very cheap and simple method to check for PNH. Which can be detected by antigen antibody reactions. A gel card test was developed, which is based on column agglutination technique. It is also a cheap and simple method to perform, but both these tests have lower sensitivity and they are not quantitative. Quantitative in 1980s and 90s, we got to know about flow cytometric testing of antigens, both on RBCs and on WBCs. Now, RBC testing is usually performed when my internet connection may be unstable right now. Am I audible?
Yes.
Yeah. So in granulocytes, we use CD24, CD157, and monocytes CD14 and 157 to check for PNH clone. So it can be very specific for detection of PNH clone. It is not interfered. There is no interference of flare by any other factor. So it is very specific. Now, so sample, you should know. So this is the old test, that is Ham's test. And the first row is from the patient. The second row is from the control. Okay, so we can see the middle tube, which is showing lysis when the serum is acidified. And heat is the control. So Jellicoe test, you can see that this is the normal healthy control, and this is the patient. This is a patient where there is no reaction for CD55 or CD59, indicating the patient is suffering. This case, and it is showing that we have with a 5-color panel, we gate out the CD45 positive cells, and from there we take out the granulocytes or neutrophils, and monocytes is orange colored population, which is CD45. 15 is a gating antigen for neutrophils, and then we check again for the monocytes with refine the monocytes with CD64, which show bright expression of CD64. And when we get both these populations of neutrophils and monocyte, we check the (157) flare, because they are old cells, they are formed before, and somatic mutation is usually acquired. So it takes years for lymphocyte to get replaced by the acquired mutation. So lymphocytes usually do not show loss of flare, and this is an internal monocytes are normal. And there is no PNH clone which will be visible here in the quadrant 4, that is double negative. The cells. Here we have gated out neutrophils and monocytes, and then refine them with CD15 and CD64. And then we check the neutrophils and monocytes respectively with respect to CD157 and flare expression. And in this case, RBC flow cytometry in our lab. So for any positive case, it is very helpful to do an RBC flow cytometry to check the types of clones that are present in the patient's blood. And it may be affected by recent transfusion. That is why thrombosis. What is the mechanism of thrombosis? Complement and thrombosis coagulation system can go hand in hand. It was known since decades. 40 to 70% of the PNH patients can have thrombosis. Venous thrombosis is more common than arterial, and hepatic vein thrombosis is very common side. One of them, where just highlighted again, my internet connection is unstable. Am I audible?
Yes.
Yeah. So next, so what is the proposed mechanism of thrombosis in PNH? There's a itself contribute to to thrombosis. Nitric oxide bioavailability is impaired, that can associate it with thrombosis. There's impairment of fibrinolytic system, and obviously there are inflammatory mediators and neutrophils that play a role in thrombosis. As Dr. Karthik already told, that more than 1.5 times LDH upper normal limit of LDH is associated with thrombosis, previous thrombotic events, presence of clinical symptoms, polymorphisms in ABO genes, and elevated level of plays a role in platelet activation. It causes nitric oxide depletion. Free hemoglobin also directly affects the endothelium and causes its activation and dysfunction. There is release of microparticles from the platelet, where we know that UPAR is one of the GPI linked protein, and it helps in plasminogen activation. And we know plasminogen forms plasmin, which is a fibrinolytic agent, and thus this efficiency of protein can complements directly can also cause increase in inflammatory cytokines, and there is activation of tissue factor when there are micro particles that are formed from the platelets. They directly cause generation of tissue factor. There is consumption of anticoagulant proteins to that neutrophils can also interact with these and promote thrombus formation, and with the release of neutrophil serine protease and nucleosomes. So, one point that I would like to highlight is that though this and thus and there are other mechanisms of thrombocytopenia as well, that is subclinical silent thrombosis, that is consumption of platelets, hypersplenism consequent to previous Budd-Chiari syndrome or liver disease. So I think if the time is a limitation, then impact of therapy and monitoring can be covered by Dr. Mukul. So handing over to Dr. Mukul. Thank you.
Hi, good evening, everyone. So I'll be discussing the part of management of PNH, especially the thrombotic aspects. Thank you, Tulika ma'am, for giving me this opportunity, and thank you, course directors, for this wonderful platform. So this is a brief outline. The epidemiology and pathogenesis of PNH has already been covered. I will be focusing on management of PNH, complement inhibitors, mainly eculizumab and other ones. Dr. Karthik has already shown this slide that the thrombotic risk is pretty high. Most of these patients have high LDH. That means it is the hemolysis, the active hemolysis, which is contributing to thrombosis. And these are your patients who have very high mortality rates. That is the patient with the thrombosis tend to have almost like 14 times higher mortality rate as compared to those without thrombosis. But there is a stark regional variations. This is this wonderful paper from the in the International Journal of Molecular Sciences published this year only, which compares the incidence of thrombosis between Asians and non-Asians. We can see that Almost all the p-values are significant here, be it the incidence rate, the history of thromboembolism, type of thrombosis, whether venous or arterial, site of thrombosis, you know, the mortality rates are nearly same, but the death from thromboembolism is very high in the non-Asian population. And unfortunately, the use of anticoagulant therapy is also very high in the non-Asian population. So this is something where variation which is there between Asians and non-Asian, which should form a part for regional management guidelines, and just highlighting that we need not follow everything which is there in the Western guidelines. Coming to the management aspects. So management mainstay in the Western world, it's mainly to block the alternate complement pathways with the inhibitors like eculizumab or ravulizumab or allogeneic transplant. But what is needed in extra is supportive therapy. These therapies do not halt or reverse the disease progression. These include transfusions, iron supplementation as the patient lose a lot of hemoglobin, erythropoiesis stimulant like danazol, steroids. They can be given during active episodes of hemolysis, usually for a shorter duration, like 7 to 10 days maximum. Antithrombosis prophylaxis, and lastly, yes, bone marrow transplant. If we look into the algorithm for PNH management, it's basically divided into aplastic and hemolytic PNH. For the aplastic PNH, if there is a moderate aplasia or a severe aplasia with or without hemolysis, the treatment is as per immune-mediated aplastic anemia with immunosuppressive therapy or transplant. If there is hemolytic PNH or aplastic PNH with the significant hemolysis, then you start with complement inhibitor therapy, and there is a risk of thrombosis in these cases. The German guidelines, they highlight more on hemolytic PNH, where if the patient is asymptomatic, you can do wait and watch therapy, wait and watch and observation with supportive therapy, and you can consider for prophylactic anticoagulation. Just mind you that it is consideration here only. And for symptomatic patient, it's always a complement inhibitor. With if there is a history of thrombosis, you can add on anticoagulation in addition to complement inhibitors. So there is this study from India which highlights the role of danazol, cyclosporin, and prednisolone as single agents or in combination. Here also we can see that the study had around 32 patients, and 9 of them, that is around 25% of them, were having some kind of thrombosis. The study highlights that the responses were seen in around 40% of the patient with the combination of prednisolone and danazol. Other combination, the responses are mostly unseen. The responses or partial responses were seen in around 40% complete responses were in with the combination, and around 75 to 80% of them have some kind of partial response. There was this question asked about use of anticoagulant therapy. So most of us will live in the place where the complement inhibitors are not available. In such a scenario, the guideline from that same paper, they say that if there is no anticoagulant therapy can be given if there is a patient do not have a history of thrombosis and who are receiving a complement inhibitor, they need not have anticoagulation as primary prophylaxis. The platelet count usually for such things are around 50,000. However, if you can consider them for anticoagulation prophylactically if there is persistently elevated D-dimers pregnancy or during the perioperative period, when the complement inhibitors are not available and the clone size is usually more than 50% and platelet counts are more than 1 lakh, you can consider these patients for primary prophylaxis with anticoagulation. But unfortunately, this anticoagulant therapy is not always effective also. This slide just show that even with the anticoagulant therapy, the patient can experience thrombosis in around 30% of the patient. And if there is prior TE, the risk can increase up to 50%. So it's not always effective. There is this SRMA about anticoagulant and DOACs, around 2043 patient years, and they just show that 19 patient treated with DOACs at around 17 and no thrombotic recurrence was seen. They went on to give this algorithm in which If the patient does not have any of the following high risk factors like previous thrombotic events or any other hypercoagulable condition or pregnancy, they can be considered for DOAC prophylaxis. Otherwise, warfarin can be used in these patients. What about transplant? Transplant is, yes, always potentially curative, but there is a chances of reoccurrence of PNH clones after transplant. In a retrospective study, the overall survival at 6 years was around two-thirds of the patients, and mortality was higher when there is prior history of thromboembolism. So, if you see that as when there is a prior history of thrombosis, patient with transplant tend to have a slightly higher mortality as per this study published around 12 years back. A few more words. So you use a reduced intensity regimes in most of these patients, or even a ablastic kind of a regime, flu or trio-based regime or biofuel-based regime. It's important whether to transplant or not. The indication usually are now, cost or resources based and on a symptomatic PNH patient with no access to complement therapy. In patient who have a prior thrombosis, C5 inhibitor, that is eculizumab or others, can be continued or else stopped up to engraftment. I'll discuss slightly in more detail with about the complement inhibitors. So what are the indication for complement inhibitors? These include patient with increased hemolysis as evidenced by LDH high, PNH clone of more than 10%, and any of the following criteria like symptomatic disease with weakness, hemoglobin urea, abdominal pain, low HB, thrombotic events requiring anticoagulant therapy, regular transfusions, like up to 4 transfusions per year, organ damage due to hemolysis, like respiratory failure or pulmonary hypertension, smooth muscle dystonias, renal failure, and pregnancy with high risk of thrombosis. These patients can be considered for complement inhibitors. So eculizumab, it binds with high affinity to C5 that attacks the terminal complement pathway. The proximal function of the complement remain intact. So there is weak anaphylatoxin is there, immune complex clearance, and microbial opsonization, which is kind of slightly preserved with these patients. This is the first study about on eculizumab, phase 2 study, phase 3 study, TRIUMPH trial, and it included patients with classical PNH, and these are the primary and secondary objective, that is stabilization of hemoglobin and reduction in the number of paxil transfusion. Secondary objective being transfusion independence and reduction in hemolysis. The classical schedule of eculizumab administration was given to these patients. But it went on to show that the fraction of patients who were transfusion free, that came out to be around 60% as compared to the placebo, significant again, and the reduction in the LDH was markedly seen. So LDH kind of stabilized to less than 500 in most of the patient as compared to the group. Eculizumab was associated with improved FACET score and reduction of fatigue. Both FACET fatigue score and EORTC QLQ C35 assessments were better with eculizumab as compared to placebo. It was pretty well tolerated, with the adverse events being pretty rare in both the arms and almost manageable or negligible events in the eculizumab arm. Then a long-term follow-up of these patients were published around some time back, and it was from 2 trials, TRIUMPH and SHEPHERD trial. This went on to show that this LDH decrease was sustained over years, and the hemoglobin stabilized but did not normalize in most of these patients. So hemoglobin stabilized around between 10.5 to 10 to 11 in most of these patients. There was a significant reduction in thrombotic events with the complement inhibitor. So before eculizumab, almost 1/3 of the patient had thrombotic events. That is 124 thrombotic events over these many patient years. But during treatment, only 7 per patient, that is 3.6% patient had thrombotic events. And this decrease was significant. And many of these patients are able to discontinue their anticoagulation therapy while on eculizumab. What about renal failure? So 64%, that is 2/3 of the patient, had CKD evidence at the start of the therapy. And more than 90% has some improvement or stabilization within 3 years of eculizumab treatment. And there is time-dependent improvement in the renal function, which was seen. As compared to mortality, the overall survival was around 97%, which was sustained throughout the treatment. over 5.5 years of ongoing eculizumab treatment. What about other complement inhibitors? So we have various other proteins in the complement pathway, that is C3, factor B, and factor D. So all these inhibitors are there. Most of them are approved in the Western world or are in various stages of trial, be it danicopan, iptacopan, pegcetacoplan, and the C5 inhibitor, but like ravulizumab or crovalimab. Most of these are available in the West. So I'll just show some comparative data over these. Uh, so first, starting with the biosimilars of eculizumab. This is a study from Austin Kulsikras and published last year, comparing biosimilar eculizumab with the original molecule. This went on to show that the LDH results were comparable almost throughout the treatment. So were the total complement result, which were mostly comparable, and the overlying lines were there in both the groups. The adverse events are also comparable across the both the forms of eculizumab. If we compare C5 and C3 inhibition, there we have a longer data with the C5 inhibition, and real world experience is there. It's clinically effective and very well tolerated with very few side effects. However, it is not effective in all the patients. Some of the patient can have a C3 related extravascular hemolysis. Unfortunately, all these treatments are IV, and there is direct and indirect cost. They are very high, as all the practicing hematologists know. About C3 inhibitors, the efficacy is slightly superior or equivalent as compared to eculizumab. The advantage is that they are available as subcutaneous treatment, and there is option for self-administration. They are also well tolerated with very few side effects. Problems are that the application is slightly higher. The administration is to be given every twice a week, and approval is still pending in many countries. The direct costs are still very high, and indirect costs are unknown with these agents. So when should you consider switching from C5 to C3 inhibitors? So when there is a breakthrough intravascular hemolysis while the patients are on a C5 inhibitor, when there is a relevant C3 mediated extravascular hemolysis which is occurring, when there is unprovoked thromboembolism which can occur despite the patient being on a C5 inhibitor, severe fatigue, or a rare kind of a condition where C5 polymorphism is there, which prevents C5 inhibitors from binding to C5. There's this another systematic review and meta-analysis published a couple of years back, which compared three complement inhibitors, eculizumab, ravulizumab, pegcetacoplan. This went on to show that the reduction in LDH was kind of similar in all the three. And the effect on rise on hemoglobin was also similar across all the three, that the mean hemoglobin was rising somewhere between 1 to 2 grams. Transfusion avoidance was seen in almost 2/3 of the patients. In 1/3 of the patients, and the odd ratio for this was around 0.61. Again, pretty much similar across all the three, slightly more with the pegcetacoplan. And the reduction in fatigue was also, the FACIT-F score were also similar across all the three. What about pregnancy and PNH? Pregnancy and PNH can have very high morbidity. Mortality can be seen in almost 20% of the patients. These patients, the guidelines say that these two are to be started on complement inhibitors preferably. There is little data with other complement inhibitors. Prophylactic anticoagulation is to be given to all these patients throughout the antepartum period and at least 6 weeks postpartum. And the monitoring frequency is to be increased. Many of these patients, as you understand, that DOACs can't be given. So most of these patients are put up on anticoagulation with enoxaparin, and which is to be continued throughout the pregnancy. The antenatal maternal morbidity is there, fetal mortality and fetal adverse events are also more common in these patients. What we do for mild and compensated hemolysis, we offer them supportive therapy with vitamins, irons, and at time aspirin. For moderate to severe hemolysis, transfusion support is offered to them. Most of these patients are put on danazol. We advise them for short course of steroid, like I highlighted, 7 to 10 days during the episodes of hemoglobin urea. Most of our patients are on prophylactic aspirin, and of late we are shifting more in many of these patients to DOACs. We have an ongoing trial for complement inhibitor at our center, so some of the eligible patients are put on that. For severe hemolysis, we also offer them allogeneic transplant. So to summarize, PNH is a disease with very high morbidity and mortality. Danazol, steroids, and anticoagulations, they're serving us good with the study already showing that the partial and complete responses are seen in a substantial number of patients. Transformed availability, experience in conditioning, and the effect on thrombosis are to be considered before when we offer these to high-risk patients. But this is something which can be of curative intent. C5 complementary inhibitors have a proven record of safety and efficacy, but the experience in Indian settings are lacking. The biosimilars and the other complementary inhibitors are the innovations which are bound to reach our population soon. This I like to thanks and invite questions. Thank you.
So I think there were a few questions earlier, but I think we've answered them. Any other questions? You can either put in the chat box or.
Thank you, Dr. Mukul, and the entire team, Dr. Tulika. So just a few points I wanted to bring across was from the diagnostic perspective. Here we have a patient who presented with the pancytopenia with a hemolytic predominant component, with the marrow showing a hypercellular marrow with erythroid hyperplasia with no variable cellularity. I couldn't find the trifine there. And presenting with a splenomegaly and having a portal vein thrombosis, probably. So that's something little, not really commonly found unless you have a, pancytopenia with an aplastic process going on and, some trifine. So just wanted you to throw some light on that, on the history perspective of the trifine and the possible mechanisms there of not having any marrow suppression and yet a pancytopenia.
So Dr. Richa was highlighting in her slides as well that the mechanism of cytopenias in PNH can be manifold. Plus the very large spleen in this patient that can
Could have
also
been
possibly a
Yes.
reason that some component of hypersplenism might be there in this patient.
Yes, sir.
Sure.
True. I agree, sir.
Yeah. So those are kind of rare situations which will happen in for the students who are listening to this. Classically, in an aplastic anemia, you don't find a spleen, so that is a given. In ITP, you don't find a spleen. So in an PNH, if you find a spleen, then you have to think of a EHPVO, which is probably was the cause here. So any other pearls of thoughts to be thought in mind, because eculizumab is elusive to us as of now, unless the patient is on a clinical trial, and we are kind of managing with the steroids and danazol and iron supplements mostly and folic acid supplements. The aspirin component, you are giving it for all hemolytic predominant patients, or only if they have an arterial thrombosis?
Actually, there's a lot of data to suggest that it doesn't really work. So you kind of have to weigh the risk and the benefit. As Dr. Mukul already showed, even patients on prophylactic anticoagulation can still go on and have thrombosis. And in fact, I was part of a couple of webinars with international speakers, and they feel that, prophylactic anticoagulation, it's not really a standard of care. You can kind of look at the situation. If you feel that the patient may benefit, you may add it. The problem with the thrombosis here, it is multifactorial. There are many factors. We don't really understand it, and that's one of the reasons why the usual prophylactic doses of anticoagulation and ecosprin fail to work in all of the patients. But in many patients, if we feel that they may benefit, we do it because we don't have anything else to do. And as you rightly said, I mean, we really need to have some indigenous products that are, accessible and effective in our patients. Transplant is something that we do offer. But again, if you go to the West, they say the results are not so good, and so they don't offer it. But in an Indian scenario, over my career, I've lost many patients of PNH. It is not a good disease. If you can't transplant them, all the supportive care that we give with danazol and steroids and other things, we think we're doing a great job. But eventually, you lose these patients either to infection or to thrombosis, or they evolve because this disease does progress. It may evolve into MDS or aplastic anemia or even leukemia in some cases. So, the life expectancy of patients is not long unless we're able to give them definitive treatment, which has only just come to India. And so I think we're not really doing a really good job with our patients.
So Mukul and Dr. Tulika, so if it is hemolytic predominant and eculizumab is not available or not accessible, what would be a threshold of considering transplant? If the match is not there, at what threshold would you do a haplo or a mud?
Well, at the moment, we are not doing haplo or MUDs for PNH. We are very fortunate. The last couple of years, we have a NIH trial which is going on, and so any patients who do not have an HLA match, we put them on the trial. And so, if you guys have patients who have no eligible match, we are recruiting, and we'd be happy to take patients. They have to be classical PNH. Bone marrow should not show aplastic anemia. So these are things that could be done. I know that some data is already there on alternate donor transplant for PNH, which is actually not very good. So again, I don't know what your experience is with doing alternate donor transplant for PNH, but we were a little hesitant with the data that was out there.
You're right. So that is why we are also hesitant in doing transplant itself in hemolytic alone patients. And even thrombosis may be a bit of a tough game to take it on. But of course, aplastic anemia, we will all transplant, whether it's PNH or non-PNH. So hemolytic anemia, is there any criteria there? I mean, I'm not too sure. Maybe Mukul has reviewed or Richard has reviewed. When do you want to transplant with or without
usually when
eculizumab?
they are transfusion dependent, the frequency sometimes described as over 4 to 6 transfusions in a year. So that has been
Okay.
used in some of the trials, but like it has been said, if there is history of thrombosis, it's already the survival with transplant is seen in less than 60. It's around 60% in. So those are your problematic patients. In fact, the data says that these patients are better without transplant with respect to survival. So just for the learning purposes, we just like to highlight that patient with splanchnic thrombosis, patient with cerebral thrombosis, these are your patient where you should investigate actively for PNH. And like ma'am has already said that the mechanism for thrombosis in PNH are multifactorial. And it's not, that's why the anticoagulant coagulation is not always very helpful. It is given it must be given during the episodes of hemolysis. Uh, Something which was a really eye-opening opener for me while preparing for this preparation was the stark contrast between the data for Asians and non-Asians with respect to thrombosis, which is, again, not very surprising because uh, almost all the Western data is kind of skewed toward thrombosis for many other disorders. But even for PNS, this difference was very starkly maintained that the Asian patients tend to have far less incidence of thrombosis as compared to the Westerners.
Yeah, I think we have crossed the time limit of 8 p.m. and there's a good discussion going on. And to summarize, for those who are, the students, when you see an anemia with increased retics and an indirect hyperbilirubinemia and especially iron deficiency, think of PNH. Patients with thrombosis, young, think of thrombosis. Look at the MCV. MCV may be a good pointer towards detecting PNH because that usually does not come in the radar of general medicine doctors usually. But then unless you reiterate that over a period of time, they are likely to miss a PNH. Yeah, with that, I would hand over to Arun Chadda from the organizing team.
Thank you. Thank you very much, sir. And good evening to all of you. Today, we are incredibly grateful to all of you for joining us in the Blood Life Savior. And we have successfully completed the 6th session of this insightful web series. On behalf of Intas Pharmaceutical, I, Arun Chada, Vice President of Intas Pharmaceutical, extend the heartfelt gratitude to all our esteemed delegates for joining us on this momentous journey for the past 6 months. A special thanks to our esteemed course director, Dr. B.G. George sir, and Dr. Joseph Jones sir for designing such a fantastic web series on blood, the life savior. And this program will be undoubtedly a valuable resource to all the DM students and the other doctors also. And we are incredibly grateful to young hematologist Dr. Karthikeya Saini for sharing their insightful case presentation, and Dr. Richa Chauhan, ma'am, for sharing the differential of this case. And we are thankful to Dr. Mukul Agarwal sir for giving the localization of this case. And further to this, we are very thankful to Tulika ma'am for the professor and Department of Hematology, All India Institute of Medical Sciences, for giving insight of this case and providing the crucial learning points and summarizing the proceeding of this unique presentation. Once again, heartfelt thankful to all of you for your gracious presence, and it's being a true pleasure being with all of you. And we are looking forward to you in the 7th session of the Blood, the Life Savior, which will be on the July 16th, 2025. And we are eagerly waiting for you to return for the next anticipated session of Blood, the Life Savior. Until then, stay safe and take care. Thank you. Thank you to all of you. Thank you, ma'am. Thank you very much. Thank you, sir. And thank you to all of you. Thank you.
Good night.
Thank you, ma'am. Good night, ma'am.